Welcome everyone. Today I'll be discussing diabetic ketoacidosis, or better known as DKA. As I found after a review of a recent emergency presentation that we as a whole, medical and nursing staff, have room for improvement to better our care given to those DKA patients. Working in a rural and remote setting, DKA is not classed as a common presentation that the staff and general practitioners see often and are not comfortable, confident, and understand the correct protocol to use as a gold standard treatment for DKA presentations. As we all know, there is only ever one RN and one EEN in our ED, and more times than often, junior RNs are the primary caregivers with no medical officer on site and limited experience. Therefore, this slide will overview DKA and the basic treatment for DKA to improve education to nursing staff, to guide their understanding and practice in the ED, and to meet competency standards 1.2, 2.2 and 3.2. The following is the triage assessment of the presenting patient. An excellent triage assessment, however, after reviewing appropriate timeframes for initiating treatment for DKA was not achieved. So the triage note is Thomas, aged 24 years old, presents with nausea and vomiting, fatigue and 4 out of 10 abdominal pain. He reports having a history of type 1 diabetes and is hard to control with his subcutaneous insulin pump. On assessment, GCS 15, pupils are equal and reactive size 3, airway patent, breathing slightly laboured at a respiratory rate of 24, he's tachycardic at 118, blood pressure is 105 on 58, febrile at 38.4, dry mucous membranes, and his BSL is 17.9. After the review, we found that pathology wasn't taken for 1 hour, IV fluids were not commenced to staff were unable to insert a cannula, and medical officer was not alerted about DKA presentation. The medical officer was told that the patient was febrile with abdominal pain and wasn't told the patient was a type 1 diabetic with hyperglycemia. The junior RN was not aware of DKA classic presentation and wasn't confident giving a provisional diagnosis to alert the medical officer of how serious the case was. The patient's blood pressure then dropped to 89 on 46 and his blood sugar climbed to 24.9 within half an hour, and he became slightly vague. Therefore, a clinical review was activated and the medical officer came to review, diagnosing DKA. Why is DKA a medical emergency? It's because diabetes is not diagnosed in 20 to 30% of all DKA presentations. The mortality rate is 5 to 15% of all cases. 70% of diabetes-related deaths in children are from DKA. It can affect type 1 and type 2 diabetes, and DKA is an acidotic state characterized by hyperglycemia with the presence of ketones in urine or blood. We need to understand the definition of diabetes to understand the pathophys behind DKA. Type 1 diabetes is an autoimmune abnormality which is characterized by the destruction of insulin-producing beta cells. It can be either relative or absolute insulin deficiency. Now, how does this cause DKA? The primary role of insulin is to facilitate glucose uptake into the cells. When the body relies on an outside source to provide insulin, it can be hard to control hyperglycemia. When there is relative or absolute insulin deficiency, peripheral glucose uptake is impaired, as most cells are unable to transport glucose into the cell without the presence of insulin. This impairment changes the body's metabolism to what is normally fed from glucose and carbohydrates to rely on fat metabolism. This process produces acidic ketones, which build up because they too need insulin to break them down. Ketones are produced due to the switch to fat metabolism, which then forms free fatty acid oxidation in the liver. The increased production of ketones causes an accumulation of ketoacids in the blood serum, resulting in metabolic acidosis. Once the body's glucose levels reach a hyperglycemic state, the renal threshold is surpassed and glucose is secreted in the urine. Glucose is a strong osmotic diuretic, meaning it inhibits water reabsorption by the kidney tubules, resulting in polyuria, leading to hypovolemia and severe dehydration. During the large diuresis, not only glucose is excreted in the urine, electrolyte losses occur as the body tries to rid itself of excess ketones. Ketones are negatively charged but carry positively charged electrolytes out of the body with them, meaning a depletion of potassium, sodium, and phosphate, as well as water and glucose. This becomes a main concern. The patient then experiences abdominal pain and vomiting due to severe electrolyte imbalance and a stress response from the body. Clinical presentation will usually be similar for all presentations depending on the precipitating cause. Some causes of DKA are infection, myocardial infarction, cerebrovascular accident, influenza, surgical emergencies, drug use, stress, or insulin administration error. These conditions can present with their own clinical picture with DKA featuring on top, which can often be missed. Therefore, DKA should be investigated until proven otherwise in all diabetic patients in the ED. Interestingly, Lenihan and Holloway find that DKA presentations are usually patients with a lower body mass index, are at a younger age, and have a new or recent diagnosis of type 1 diabetes. Young children are found to commonly present in DKA due to undiagnosed diabetes. Children younger than 3 were reported to have 54% risk for DKA. The chief complaint for DKA usually is malaise and fatigue. They just don't feel right and they are extremely exhausted. This is due to no glucose within the cells for the body to use for energy. Confusion is usually a late sign of DKA and is from the pH shift of metabolic acidosis if it's worsening. Buckley and Murphy find that nausea and vomiting and abdominal pain is not fully understood, however believe it is a result of delayed gastric emptying, an ileus, subacute pancreatitis, esophagitis with ulceration, or bowel ischemia. However, Marib and Home believe it is due to severe electrolyte imbalance. Dehydration, dry mucous membranes, diminished skin turgor, and excessive thirst is caused by polyuria from the osmotic diuresis which we have just spoken about. Hypotension will be caused from hypovolemia from the huge diuresis, sepsis, or both. Dysarrhythmias may occur due to electrolyte imbalances, however the dominant cardiac rhythm is sinus tachycardia. Kushmal respirations are characteristic of deep hyperventilation to help blow off CO2 to increase blood pH, and a fruity acetone breath will be noted as the patient exhales excess acetone. Initial assessment is the responsibility of the triage nurse, although ongoing assessment should be taken every time the patient is approached. The ABCD algorithm should be used as a primary assessment to gauge potential or actual threats to airway requiring an airway adjunct, breathing requiring assistance to ventilate and oxygenate, whether it be supplemental low or high flow oxygen, non-invasive ventilation, or invasive ventilation, depending on the severity of the respiratory distress. Circulation, assessing for hypovolemia, arrhythmias, and circulatory disturbance requiring pharmacological support or intervention. And disability, assessing the patient's level of consciousness using the Glasgow Coma Scale or the AVPU scale. Once the primary assessment is complete, it is imperative to work quickly to confirm the diagnosis. This is done by an extensive history, laboratory test, urinalysis, blood glucose level, and an ECG, which should be attended to as soon as possible or within the hour to diagnose DKA and rule out precipitating causes. At this time, 2 large bore cannulas should be inserted. And if we just go back there, you can see that DKA is confirmed with a blood glucose higher than 13.8, ketones in urine and blood, and metabolic acidosis with a pH less than 7.3 with severe dehydration. Gills described basic treatment for DKA as insulin replacement to correct hyperglycemia and hyperketonemia, volume replacement by intravenous fluids, electrolyte replacement, and to treat precipitating cause. Each emergency department will have their own policy and procedure guideline for the treatment of DKA, and today I will be focusing on our hospital's policy and what our rural capacity is. Hunter New England Health Policy depicts the first 2 hours of presentation as the resuscitation phase. During this phase, 2 large bore cannulas must be inserted, an arterial blood gas taken on arrival, a full set of pathology including blood cultures, an MSU, and a chest x-ray. These will help find a precipitating cause. Hourly venous blood gases is essential as well as vital signs, blood glucose, and ketone testing. Once IV access is obtained, fluid and electrolyte replacement must commence. A stat infusion of 1 litre of normal saline to correct hypovolemia and repeat if necessary, and this must continue at a 500 ml rate for the next 4 hours depending on clinical picture. Then to commence potassium replacement prior to insulin therapy. Why is this? It's because insulin drives potassium back into the cell, causing severe hypokalemia. Then commence IV insulin via syringe drive at 5 units per hour until BSL is less than 15 millimoles. Do not turn the insulin off at this point, as ketoacidosis is still present and takes a lot longer to correct than hypoglycemia. To prevent hypoglycemia though, commence 5% glucose infusion and titrate to BSL. By this time, retrieval should have arrived to take the patient to referral hospital where endocrinologists can take over care, and they will switch to subcutaneous insulin when blood ketones are less than 0.5 and the pH is normalised. Just some important facts here. Insulin continues even if the blood glucose level becomes normal or low. Start glucose 5% or 10% to maintain BSL. Hyperglycemia may have been corrected, but ketoacidosis corrects much slower. The most common mistake is to reduce the insulin infusion as the BGL falls. It takes up to 24 hours for ketoacidosis to reverse, and blood ketones should be less than 0.5 millimoles with a normal pH before cessation of insulin infusion. Insulin should be administered by a syringe driver and a 50 ml syringe with 50 units of Actrap and 50 ml of normal saline. 10 ml of the solution should be flushed through the line before connecting to the patient to ensure tubing is coated with the solution as the insulin adheres to the tubing. Do not let blood glucose fall rapidly as this can cause cerebral edema, and blood glucose levels do not need to be elevated in DKA. This is due to a depletion of liver glycogen. All diabetics should test urine for ketones if feeling unwell. This presentation has mostly been aimed at adult patients, so just quickly some tips on caring for the paediatric DKA patients. Children are at much higher risk of cerebral edema than adults, but they can handle hypovolemia well. And fluid correction is over 48 hours instead of 24 hours in the adult. Kaleidoscope at John Hunter Hospital have their own policy for children in DKA if you would like to look that up. Thank you, and hopefully this has given you a basic overview of what diabetic ketoacidosis is and how you as a nurse are expected to detect, assess and intervene to provide treatment for our patients that present to the ED. If you have any questions, please fire away. Thank you.